Again, I'm repeating, TBW is something which we are going to have a discussion on when we will discuss about the lower limb trauma, because the same principle, tension band wiring, is used in the management of patella fractures also, and there we are going to have a detailed discussion of tension band wiring. This is just what we are expecting. That's why we have portrayed this one. All right. Next comes the dislocation of the elbow joint. You know, the possible dislocation of the elbow means that the articular congruency in between olecranon, the distal end of the humerus, and the radial capitellar congruency is disintegrated. So, elbow dislocation, the most common type of elbow dislocation is posterolateral. All right. That means the distal part of the elbow, which is olecranon process in particular, it is displaced posteriorly and laterally more commonly. So, elbow dislocation more commonly is posterolateral type. This is only one thing that you have to remember for this. Now, as far as management is concerned, simply you have to put it on the table in 90 degrees of flexion, and then you have to apply traction onto the forearm. It will be getting reduced immediately. All right. So, that is the management for elbow dislocation. If at all they ask any question related to this particular topic, then this is your question, that which of the following is the most common type of elbow dislocation. All right. And that is posterolateral. Next. Now, this is the kind of the question which they have asked multiple of the times previously, but there was a gap where this question was not repeated very frequently. But in 2020 NEET PG examination, they have asked this question again, and it became significant because you should be aware of this. It is a kind of the condition which can happen in any house or in any of your relatives, which you could be able to, or which you should be able to manage accordingly. The question is, or the topic is, pulled elbow or the nursemaid elbow. Now, whatever is mentioned in the question are the clinical features for that particular. Point number 1, father of a 4-year-old child. Now, they will always give you a history which is relevant, which is significant. They will never give you a history where mother is holding the child and playing with the child in a swinging way. All right. Or mother is pulling the child with the arms and playing in a swinging way. They will never give you this. It could be a work of either father or any of your relative. So, father was playing with a 4-year-old child while lifting the boy with both hands. So, lifting the boy with both hands. Now, child suddenly started crying. Now, what has happened with this? This is the mechanism of injury which has been mentioned clearly in the question, that father was playing with the child, lifting both his hands. All right. This is the mechanism. And this mechanism has resulted in the dislocation of the radial head out of annular ligament. So, what is pulled elbow or nursemaid elbow? It is the radial head dislocation. Radial head dislocation out of annular ligament. Dislocation of the radial head out of annular ligament. This is what the pulled elbow or the nursemaid elbow is. Next. So, when the father was trying to play with the child by lifting both his hands, one of the joint is dislocated out of annular ligament. So, what the child will do? Child has started crying, holding the elbow in pronation. That means this is how the elbow is held, and extension, not only in pronation but extension also, pronation and extension, and not allowing anyone touch it. Obviously not. There is a observable swelling around the elbow. So, first of all, just by reading the question, you came to know that there is a mechanism of injury and the clinical features which are mentioned in the question itself. And now comes the management part. So, what or how to manage it? So, just by looking at the picture, you came to know that this is pulled elbow. Now, you have to do the management. What is the management? You have to reduce this radioannular ligament. How to reduce it? What you will do? You will flex the elbow and supinate it. All right. You will supinate it and flex the elbow. It will be reduced immediately. But following reduction, no immobilization is required. No slab application, no elbow pouch, no arm pouch, no immobilization of any sort is required. What you have to do? Just deviate the attention of the child, supinate it and flex it. Supinate the forearm and flex it. So, this is what is achieved by closed reduction. So, what is the answer for this question? Closed reduction and internal fixation? Obviously not. Open reduction, internal fixation? Obviously not. No fixation is required. Closed reduction without immobilization seems to be the correct answer. closed reduction and slab application, as I told you, no immobilization, no support, no sling, no pouch, either in the form of elbow or arm, is provided following the reduction. So what is the management? Treatment is supination. You just have to supinate it and then flex the elbow. All right, and no immobilization is required. So this is how you can manage the condition. And this is the reason why the examiner is keen on asking this question, which can be managed at home in particular, if you are aware of that what exactly is pulled elbow. So hope everything is clear related to these topics. Now, just having a quick discussion on what we have already discussed, like after lateral condylar fractures, we have talked about the olecranon fracture. We have talked about the elbow dislocation. As I told you, tension when wiring is going to be discussed in detail in the lower limb trauma. We have talked about the elbow dislocation. The most common type is this one, and the pulled elbow and the nursemaid elbow. All right. Everything you came to know about this. Let's have a discussion on the carpal bone. Now, anatomically, you are aware of that how these carpal bones are arranged in the wrist. We are very well aware of the mnemonic, which you are studying right from your anatomical classes in first year, that scaphoid, then lunate, then we have tracheateral, then pisiform, then in the distal row from the lateral aspect there is a trapezium, then trapezoid, and capitate and hamate. All right, so this is how the bones are arranged. But nowadays the examiner wants you to identify the name of the carpal bone which is being highlighted. For example, if they give you this X-ray and they just highlight any one of the bone like this one, all right, they highlight this bone and then they ask you what is the name of the carpal bone which has been highlighted. So this is the practice that you have to go through. All right, that despite knowing about the arrangement, you should also know that what is the name of the bone in the carpal row which is being projected or asked on the X-rays. Next, as far as from the orthopedic significance is concerned related to the injuries to the carpal bone, you already are very well aware of the fact that the most commonly fractured carpal bone is a scaphoid, and after scaphoid it is lunate. So scaphoid and lunate are considered to be the most commonly fractured bone in the carpal. All right. Now, before we jump on to the discussion of the scaphoid fracture, let's have a sample question related to the fracture, that which of the following is incorrect regarding scaphoid. And if you read out the options, the first one is AVN is more common in the proximal fragment. Second, persistent anatomical box tenderness or anatomical snuff box tenderness is highly suggestive of the fracture. The third option is malunion is a common complication, and the fourth option is immediate X-ray might not reveal the fracture site. All right, so you are having these four options related to that particular topic. At the end of the topic, you yourself would be able to mark the correct answer. But before that, let's talk about the scaphoid fractures. The first one is, which we have already talked about or discussed, that it is the most commonly fractured carpal bone, scaphoid, and the second most commonly fractured bone is lunate. All right, the second bone in the proximal row after scaphoid from the lateral to the medial aspect. Then point number 2, anatomical snuff box tenderness. You know, if the question comes where there is a history of trauma to the wrist and the patient is having an anatomical snuff box tenderness mentioned in your question, possibly the examiner is asking about scaphoid fracture. So it is considered to be a hint provided to you in the question. That is anatomical snuff box tenderness. Now, you know, there are several anatomical considerations related to the scaphoid fracture. Some trauma related considerations, like it is a bean-shaped bone, it is having a DISI deformity, the position of the wrist has to be in flexion and ulnar deviation at the time of impact. But examiner is not at all interested in asking about these insignificant considerations of the scaphoid. What is important is, or what the important point related to scaphoid fracture is, are the complications. Because if there is a fracture of the scaphoid, if it is neglected or if it is managed, then the complication is something which you should be aware of. So let's talk about the complications. Before we try to discuss what has been written over here, it is essential or important to have a discussion on that what is the vascular supply to the scaphoid, or how the vascularity to the scaphoid is arranged. Imagine this is the scaphoid bone, all right, and this is the proximal fragment, sorry, this is the distal fragment and this one is the proximal fragment. Proximal means it is near to the radius and the distal fragment is adjacent to the carpal bones. Now, the vascular supply to the scaphoid is such that the proximal fragment is entirely dependent on distal vascularity. There is no individual or independent vascularity to the scaphoid. There is no individual vascularity to the proximal pole of the scaphoid. So, the proximal pole of the scaphoid is having precarious vascularity. That means insufficient vascularity. And this is a disadvantage to the scaphoid bone, which makes it more prone to get complicated after the fracture. Alright, the reason is precarious vascularity, insufficient vascularity to the scaphoid. The proximal pole is not receiving the independent vascularity, it is dependent on the distal vascularity or the distal pole vessels. Now, imagine if there is a fracture happening at 3 different levels. Imagine there is a fracture at level A, at level B and at level C. Now, what is going to be the different prognostic outcome of that? If there is a fracture at the level A, the possibility of avascular necrosis to the proximal pole. If there is a fracture A, the possibility of AVN, avascular necrosis to the proximal pole will be there. But if you compare the fracture B and A, the possibility of AVN will be higher with the fracture B and it will be highest with the fracture C. That means proximal the fracture, greater the chances of avascular necrosis. And second is, because it is having relatively insufficient vascular supply, the possibility of non-union at the fracture site is also higher. So these are the two complications. One is osteonecrosis, that means avascular necrosis, and the other one is non-union. Alright. Now, it is very clearly evident that if there is a fracture and one of the fragment has to go into AVN, then the proximal fragment will go into AVN. The chances are higher in comparison to the distal fragment AVN because no independent vascularity to the proximal pole. And this is all what we have written over here. Now, what are the key words which you have to focus on as far as complications are concerned? One is osteonecrosis or avascular necrosis, which will be more in the proximal fragment compared to the distal fragment. It does not mean that the distal fragment will not go into AVN. There is a possibility of distal fragment AVN also, but proximal is more commonly affected. Second is non-union. And if you compare the different fracture sites at different level, then proximal the fracture, again go back to this image, proximal the fracture, poorer the prognosis, because nearer the proximal pole, if there is a fracture, it will be having higher chances of AVN, it will be having higher chances of non-union. So proximal the fracture, poorer is the prognosis. So this much at least you need to remember about this scaphoid fracture. As far as the management or the treatment of this scaphoid fracture is concerned, it can be managed by two ways based upon the displacements. Now, if a scaphoid fracture is undisplaced, that means there is no displacement, then you have to put the scaphoid cast, or it can be managed by the placement of a scaphoid cast. Now, what is a scaphoid cast, or what makes it peculiar for you to identify the scaphoid cast? In a scaphoid cast, the wrist is immobilized in. The wrist is immobilized in extension, that means dorsiflexion, alright? Extension, and thumb is immobilized in abduction. Alright? So the wrist is immobilized in extension and the thumb is immobilized in abduction. So it appears like as if you are holding a glass, and that is the reason why it is called as glass or cup holding cast. Alright? Scaphoid cast is given a name, that is glass holding cast. So in case of Colles fracture, you came to know how the cast will look like. In case of Smith fracture, you came to know, and in case of a scaphoid fracture,